Hello, everyone. My name is Chanel Blackwood, and I am the marketing manager at IKEA. Welcome and thank you for registering for today's workshop, Financing PHC in LMICs, Putting People at the Center. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded onto the IKEA website app afterwards. Before we get started with today's session, I just wanted to run through a couple of housekeeping items. If you experience any technical issues during today's webinar, please feel free to type them into the chat box at the bottom of your screen, and I'll be happy to assist. Everyone on the line has been muted except for our speakers in an effort to eliminate background noise. If you would like to speak aloud, please feel free to use the raise your hand function and unmute. We'll be holding all questions until the end of the session when we'll open for a facilitated Q&A. I'll now pass things over to Laura. Laura, over to you.
Yes, so good day, everyone. I'm Laura Anselmi. I'm a senior research fellow in health economics at the University of Manchester and a co-convenor of the special interest group on financing for universal health coverage. So I'm very pleased to welcome you today to this webinar on financing primary health care in low and middle income countries, putting people at the center. The focus of the seminar is going to be on some of the findings from the Lancet Global Health Commission that were published early this year. In particular, today the focus will be on resource allocation and on provider payment. We've got a set of 5 speakers that I'm going to introduce very briefly now. We've got Professor Kara Hanson, who is Professor of Health System Economics and Dean of the Faculty of Public Health and Policy at the London School of Hygiene and Tropical Medicine. She's the principal investigator of the Lancet Global Health Commission on financing primary health care. We also have Dr. Shankar Prinja, who is currently the Executive Director at the Indian National Health Authority, where he heads the Division of Health Policy and Quality Assurance, and is responsible for designing health benefit package, pricing, development of standard treatment guidelines, and quality assurance measures for the Indian National Insurance Scheme, the Prime Minister Jan Arogya Yojana, PMJ. We have also got Professor Timothy Powell-Jackson. He's Professor of Health Economics in the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. He has 15 years of research experience working in low and middle income countries and applying an economics lens to the understanding of how health systems work and how they can perform better. We have also got Dr. Triin. She's a senior health economist at the WHO Barcelona Office for Health System Financing. Before joining the WHO, she held different positions at the Estonian Health Insurance Fund and Ministry of Social Affairs in Estonia. Her work has been mainly focused on all aspects of health system financing, but also on transforming hospital and primary care provider networks. We have also got Dr. Darius Erlanga. He's a senior research fellow in health economics at the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. As a medical doctor from Indonesia, he received his doctoral degree from the University of York, analyzing the impact of the Indonesian social health insurance program. His work has mainly been focused on health financing of primary health care, but also on the quantitative analysis of corruption practices in healthcare facilities. I'm now going to hand over to Darius, who will introduce more in detail the plan for today's presentation.
Thank you, Laura, for introducing the speakers. Hi, everyone. My name is Darius Erlanga. I'm going to introduce the sessions. I'll have some screens to share. Yeah, I'm part of the Lancet Global Health Commissions on financing primary healthcare, and who we are. Let me introduce you who actually are. So we are divided into 2 groups: the commissioners and technical team at LSHTM. The commissioners is chaired by Professor Kara Hanson from LSHTM, and then for the commissioners is a mix of policymakers from around the countries, from We also have experts in technical agencies, from donors, universities, and think tank. This is the list of the commissioners that we have across the world, I would say. And this is the list of the technical team that supports the write-up and of the report itself. So first of all, I'm going to start by setting the scene for why this support is needed. I'd like to highlight the importance of primary healthcare in a country's health system. First of all, primary healthcare is designed to provide essential health services, particularly on the prevention and treatment of chronic conditions. Primary healthcare also plays a role in responding to epidemics, as we have witnessed it in the COVID pandemic recently. And primary healthcare should be regarded as a prerequisite for achieving universal healthcare and social development goals. However, even though we had this primary healthcare agenda since 1978 in Alma-Ata, the evidence showed that funding for primary healthcare is often insufficient, and health facilities often don't receive adequate financing to work properly. Government in low-income countries, as per our analysis, only spend $3 per capita for primary healthcare, which is very low. And then inappropriate financing incentives that we saw happening across countries could lead to inefficiencies and poor performance. For example, in some settings, facilities respond to lack of resources by charging user fees, which then creates financial burdens on patients. And then these higher burdens mean it further exacerbates the inequalities in access to care. And lastly, COVID-19 has created this window of opportunity, so highlighting the dangers that societies could face without a well-functioning primary healthcare system that is designed to protect everyone. So the objectives of our report is to present new evidence on level and patterns of the global expenditure on primary healthcare. We also analyze the key technical, and one thing that we highlight is the political economy challenge faced in financing primary healthcare. We identified some areas of proven or promising practices that can help countries to increase their health financing functions. And then we also identify some actionable policies to support countries in raising, allocating, and channeling resources to deliver the primary healthcare. And in doing so, our analysis is centered around this framework. Inspired by the classic health financing functions, we can see that we have first the revenue mobilizations and poolings, the resource allocation for primary healthcare, and provider payment for primary healthcare. But also, we also recognize the political economic context that's going to influence all three aspects that I mentioned before. And for the data, we got our data from several works. For example, we had case studies from 7 LMICs and 3 high-income countries, and we also extracted primary healthcare data from WHO and OECD, and we also had our provider payment survey in 78 LMIC. However, I can go and to talk about the whole findings, but for this webinar, we're going to focus on the findings from provider payments with the case study from Estonia, and then the second one will be about resource allocation with the case study of India. So right now I'm going to introduce our first speaker for the provider payments, Professor Timothy Powell-Jackson from LSHTM. He's going to set scenes of the provider payment landscapes in countries, and then followed by a presentation from Triin, who is going to present a case study from Estonia. Over to you, Tim.
Great, thanks, Darius, and warm welcome to everyone who's joined. So in the Commission, one of the working groups was on incentives. And within incentives, a big focus was on provider payment methods and mechanisms. And if you look at the Commission report, there's a substantial chapter on incentives and provider payment mechanisms. So I'm just going to present a few slides which are sort of setting the scene a bit, and then move into some of the core messages and findings. So we did a survey of provider payment mechanisms globally, and we sent a questionnaire to 107 countries, low and middle income countries, and we ended up getting 75 responses. So we have these data about provider payment for 75 countries. And this first slide is about user fees, and it shows that the prevalence of user fee policies increases as you go down the income of countries. So low income countries, there are very few countries which have no user fees. But as you go up through the income categories, more and more countries have no user fees in the public sector primary care level. And I'm sure that will not surprise anyone. When you look at the National Health Accounts data, you see a similar pattern in terms of what proportion of health financing is funded by out-of-pocket spending. Next slide, please. So the next slide then is about how public primary healthcare providers are paid in low and middle income countries. And we've had to group some of the provider payment mechanisms here, but hopefully the pattern is fairly clear. So capitation as a method of paying public primary healthcare providers is really quite rare in low-income countries. Becomes more of a predominant or a significant payment method as you move up the income ladder. And also of note is the fact that input-based budgets, so kind of line item budgets, global budget, is the predominant method of payment in the public sector in low-income countries. And then the final slide here from that survey is about the degree to which primary healthcare providers in the public sector have autonomy over certain functions and aspects of care provision. So, for example, can public primary healthcare providers procure their own medicines? Can they hire their own staff? And I think the general message here is that there is a fairly low level of autonomy. This is across all the low and middle income countries that responded to the survey. And it's perhaps not surprising that providers are not able, or very few countries allow their providers to hire and fire staff, top up salaries. There seems to be a bit more autonomy around procurement of medicines. But I think here we felt, the general picture here was that there was low levels of autonomy in what public primary care providers can do in terms of these functions. So that's just to set the scene, and in the report, of course, there's plenty more detail. So the first part of the chapter really hones in on justifying why there is a need to get incentives right. And a lot of this was based on analysis of the literature and some of our case study work. So the way providers are currently paid often works against the objectives of primary healthcare. One key example is creating financial incentives that generally prioritize curative rather than preventative care. And also something which we felt is often missed or not understood or appreciated enough is that provider payment policies are actually integral to the elimination of user fees and informal payments. So that user fee argument is not a separate debate. Provider payment policies are actually key to the user fee and informal payment debate. It's frequently observed, and there's plenty of evidence from the literature that funding to primary healthcare providers is fragmented. So lots of different funding flows reaching health facilities with different payment methods that are not coordinated and are rather ad hoc. And as I mentioned, input-based budgeting is very common in low-income countries, and that this payment method fails to provide the right incentive environment for people-centered primary healthcare that is focused on equity. And then just a final sort of observation is that when we're discussing different types of payment methods, no single payment method is perfect, is a silver bullet. Okay, they all have their advantages and disadvantages. And it's not about necessarily picking one and going, that is the only payment method that is going to work. And that leads on to our main recommendation, which is around having a blended payment method, as we'll come on to on the next slide. So the way primary healthcare providers are paid and the incentives that these payment mechanisms create are a tool and, of course, an opportunity to ensure that resources reach frontline providers and that these resources are used efficiently. And as a commission, we honed in on population-based or capitation payment as a method that creates probably the strongest incentive environment for providers at the PHC level to deliver people-centered care. And listed in the bullet points, there are some key reasons why we felt that that was the case. So capitation has advantages, but it also has drawbacks. Most notably, it can incentivize under-provision of care and potentially unnecessary referrals. So this led to the main, I guess, message from this this working group in this section of the report was that the Commission felt that as a vision, countries should take steps to work towards their own context-specific blended payment model for PHC, but one that has capitation at its center. Each country will find their own path there, and each country will have their different version eventually of a blended payment model with emphasis on different payment methods, perhaps a different balance of emphasis. But we felt that the blended payment model with capitation at its center was something that countries should set as a vision to work towards over the long term. And just to give an example, you may have capitation, but you may then have a budget payment to cover unavoidable fixed costs. You may have a fee for service component for high priority health conditions that are perhaps under incentivized. And you could also add on perhaps performance-based payment on top of that to incentivize particular actions or healthcare interventions. So the question is then the how. How do you move towards that vision? So this chart tries to encapsulate some of those answers. This charts out a progressively more sophisticated payment system as you move towards eventually a blended payment method. So moving from the status quo, whether it's in many countries a budget payment system or potentially fee for service, it's moving away from that status quo to, first of all, a simple capitation that then becomes more sophisticated with certain adjustments for different population characteristics that are based on need, and then eventually moving towards a blended payment method that can bring in different payment methods. And underpinning that is what we call basic functions that need to be strengthened as you move towards this more sophisticated payment method. So strengthening the information systems, purchasing capacity, provider autonomy and capacity, and the strength of the public financial management system. So that's a very high level overview of what's in the report on payment methods. Clearly, this is not country specific. Each country will chart their own pathway towards this vision, should they choose to do that. So thank you, Darius, and over to Triin.
Hello. Hello to everyone. Can you hear me? Yes. So during the next 10-15 minutes, I try to tell you briefly the story how in Estonia primary health care reform has evolved, just to put all this payment reform into context. But then I also try to draw some lessons, like it's on the primary healthcare payment methods. Next slide, please. About the country context, Estonia is a small country, around 1 million people, and Estonia started major health system reforms, including house financing reforms, about 30 years ago. And when these reforms were designed, and then when they were like in the very early phases, Estonia was also lower middle income country. Then Estonia switched to upper middle income country group. And then for the last more than 15 years, Estonia has been high income country. So, but really, when Estonia did major health system reforms, then Estonia was middle income country. And when we put that into health budget perspective, then the budget was very much constrained. When we look currently at health expenditures, then Estonia spends about nearly 8% of GDP on health, which if we compare with other high-income countries, then it is relatively low. Public spending is nearly 80%. So it's again, if we compare across all countries across the world, then it is relatively high. But again, it's in high-income countries group. It is rather in the middle. And one part what has been very important precondition for any kind of health financing reform and then payment reform has been that Estonia has a health insurance system, single payer system, already for the last 30 years. So around like if all payment system reforms, all health financing reforms were very much around one single payer organization. Next slide, please. Primary healthcare reform timeline. Reform can be split into four main phases. The first phase, which started in 92 and then lasted for 5 years, was more like a preparatory phase. The preparatory phase for primary healthcare reform to start. And during that period, in the university, family medicine department was established, as well residency program for medical students on family medicine was introduced. And also it did all this kind of university work and then putting kind of creating space for family medicine, created an opportunity to have more like academic work also in family medicine. And that is very important because the biggest advocates for the upcoming primary healthcare reform were actually was actually those family doctors who were closely related to the university. Reform itself started in 98. It was a very comprehensive primary healthcare reform. It's not only health financing reform. It introduced comprehensive changes in primary healthcare organization, and family doctors were granted kind of full autonomy. They became private entrepreneurs, so they were like fully private providers. And who were owning the patient list. So that gave for them a very clear room in the health sector, in the health system. And another very important feature of Estonian primary healthcare reform has been that there is a very clear and strict separation of family medicine and specialist care, because historically Estonian health system was very much hospital-centric, specialist care-centric, but the aim was to introduce family medicine principles-based primary healthcare, and over the time to also increase the role of primary healthcare doctors. And therefore it was foreseen that the most important is to have a clear separation between hospital care and primary healthcare. And during the reform, also the aim was that every person can choose their primary healthcare provider. And then when the 5-year transition period of the primary healthcare reform ended, then those people who were not choosing their primary healthcare provider, they were assigned a provider. So it ended up with a mandatory assignment. But that was to make sure that whole population in Estonia is covered with primary healthcare providers. Then after like 2002, when primary healthcare reform ended, it started like it's more like a fine-tuning period which lasted more than a decade. It doesn't mean that it was like it's very quiet and then nothing really changed. It was actually a very active period when, for example, also in health financing and then in the payment system, several adjustments were introduced. For example, during that period, quality bonus system or pay for performance system for primary healthcare was introduced. And the last and the fourth phase of primary healthcare reform started about 5 years ago, when it was clear that this kind of solo practice, small team primary healthcare system is not sustainable, and there is need to have a more multidisciplinary approach to incentivize very explicitly group practices, but also to incentivize expansion of primary healthcare team. So it's not only doctor and nurse, but also other specialists working closely with them. And during that period, what has been crucial is external fundings through the European Union Social Fund, which made capital investments available for primary healthcare. Next slide, please. Primary healthcare payment reform. Since very beginning, Estonia switched not to full capitation model. Estonia switched to blended primary healthcare payment model, meaning that capitation formed the core of primary healthcare payment model. But in addition to that, there was a fixed budget, so it's a basic monthly allowance. Initially, the aim was that it will facilitate investments in primary healthcare centers. But later on, it was transformed to cover the fixed cost of the facility. And also from the very beginning, there has been fee-for-service fund, which relates to the family doctor's function to become a partial fund holders. So which means that certain diagnostic tests, certain procedural activities, which even primary healthcare doctor and nurse are not able to conduct themselves, they can contract them out, outsource them from hospitals or laboratories or other diagnostic facilities. And another important part of primary healthcare reform was that the Health Insurance Fund introduced direct contracts with family physician practices, so which is in line with a separation of hospitals and family medicine. So it meant that family doctors received their separate budget allocation, and they were fully autonomous to decide what they will do that, and then hospital budget, everything remained fully separated from that. Next slide, please. In this slide, you can see how the mix of different payment methods for primary healthcare has been evolving over time in Estonia. So on the left side, you see 2003, which was the first year of the primary healthcare reform transition period was completed. You see that more than 70% of primary healthcare budget was covered through capitation payments. And if you compare that with current year, then you see that the role of the capitation payment has been decreasing significantly over time. And now it is even less than half of primary healthcare budget. Another feature what you can see is that it's if you compare columns on the left and right, over time, more and different payment incentives have been added. And in Estonian context, where primary healthcare providers are private, they're very autonomous, it it seemed that it works better if new and new tasks and the new functions are not blended on the capitation payment, but they will be added as explicitly as a separate incentives. For example, you see that it's currently about 7%. About 7% of primary healthcare budget is allowance for second nurse. It has been a priority to make sure that it's to who is a family doctor, not only one nurse is working, but two nurses, to make sure that there is enough time to focus on preventive activities. It's not a mandatory, it's only financial incentive. So those practices who have this nurse available, they receive additional lump sum funding. And then by now, it's more than 70% of family medicine practices do have second nurse. So it's without being a mandatory, financial incentives clearly incentivize change in the way how services are provided. Next slide. So if to draw some key lessons from Estonian primary healthcare reform, it's important to highlight that payment reform has been part of the comprehensive, much broader primary healthcare reform agenda. And what has been making sure that it's over time, there is a kind of constant continuous development is that the policy objectives have been consistent over time. So they have been, of course, objectives have been becoming more ambitious, like recently moving to multidisciplinary primary healthcare practices. But there is a consistency and no big major changes. And also very important has been that there is a broad political consensus. So across all political parties, there is no it's a different opinions, and that has assured it's that primary healthcare has been able to develop over time. External funding, although it's not very significant if we look at it's a share of the budget, overall budget, it still has been playing a crucial, important role. For example, it's a recently European fund funding available to support capital investments. It has been playing very important role and then kind of external incentive to make changes in the service delivery model of primary healthcare, but also to revise other payment incentives. So it's for example, to introduce a separate payment incentive for multidisciplinary primary healthcare group practices. And the last topic or the last lesson I would like to highlight is really the role of digital data. When Estonia started, it switched to capitation payment for primary healthcare doctors. Starting from the very beginning, family doctors asked that if it's a capitation payment, we don't have any it's a requirement to record our activities and to report on that, but they said that we would like to do some scientific work, but also we would like to compare our performance with our peers' performance, etc. And they asked whether Health Insurance Fund can make it possible that although they have a capitation payment as a major payment, can they report their basic activities like it's office visits, some basic tests. So and Health Insurance Fund was open to do that. Which means that since it's already since first years of this century, there is comprehensive activity information available, although the main payment system is still capitation. So I will stop here. Thank you so much.
That was great. Thank you so much, Tim and Triin. Yes, please, everyone who has got some questions, start typing them in the chat or feel free to raise your hand. We started having some questions in the chat. There was a very first one for Tim that was asking to recap very briefly the difference between the adjusted capitation and the blended model, perhaps with a couple of quick examples?
Yes, so very briefly, a simple capitation would be a per capita amount that is the same everywhere. An adjusted capitation amount incorporates information or data on the population that tries to capture differences in health need, so that when you incorporate this information, different people will essentially be allocated a different per capita amount. For example, if you take age, the costs or the healthcare needs of older people are going to be greater, so that would be incorporated into the capitation formula or method. A blended payment system, though, brings in different payment methods. So it might be capitation alongside a fixed budget with perhaps some fee for service in addition, such as the Estonia example demonstrated. So that's about using different payment methods. Hope that clarifies the question. Thanks.
Then we had a question from Cara for Triin. I don't know whether, Cara, you want to ask it directly yourself?
Sure, I'm happy to ask it myself. So Triin, I think those comparisons of the kind of the payment mix over time is really interesting. And I guess I'm just sort of thinking how it relates to our recommendation that capitation should be at the core of a blended system. Yours is like becoming more and more blended over time. And I'm wondering if there are any risks of that in terms of the incentive environment just becoming really noisy. And I often think about this, you know, what does it feel like to be the provider with all of these different funding bases, and do they know what to respond to anymore as the environment becomes more noisy? And do you see in the future any sort of further consolidation of that, or do you think that the future is one of increasing fragmentation of that payment system?
Thank you, Cara. It's absolutely a relevant question, and that is actually my fear as well. Of course, if you compare with hospital, like a DRG system, it's still relatively simple. But from the primary healthcare perspective, it is quite complex already. The reason of that is related to like it's how much of current family medicine kind of tasks and responsibilities is mandatory, and how much of that is actually kind of voluntary basis. And that is one of the reasons, for example, the second nurse, having a second nurse, it's still not a mandatory requirement. I would assume that if it becomes a mandatory, that per one family doctor, there should be 2 nurses. So maybe some additional, like it's a criteria link. It would make sense to incorporate it into capitation payment. But as far as it is voluntary, so then probably it's at least in Estonian environment where we have private providers, autonomous providers, it works much better. So I hope it explained a bit why it becomes a bit, and we expect like every year family doctors should do more and more new functions, and then for every new functions there will be a separate payment line.
Yeah, no, that's really clear. I guess there's a sort of sense of what's the end point there. So is it going to continue to get more fragmented, or do you reach kind of like max fragmentation?
I hope so,
that's
because
very dynamic, isn't it?
Yeah, yes, and that I think it kind of also related to the kind of what developments are there related to primary healthcare service delivery model. So when multidisciplinary group practices become like it's a default mode of primary healthcare delivery, probably then is a time to really switch to the new, like it's to review all like its payment incentives. So that would make sense.
Yeah, and actually that just reminds me of a general point that I'm not sure if we highlighted it in the report so much, but it's really clear that any payment system has to be responsive and nimble, because you have to constantly tweak the incentives. It's not like you set them once in stone and it is ever thus. Providers are clever and strategic, and they will adapt in a self-interested way to however you pay them. And so being able to alter the incentives at the margins feels like it's quite an important part of a provider payment system that's up at that top end of that trajectory towards a more complex payment system. So I'll stop looking now. Thank you.
Yes, and I think I was just wondering whether this increasing fragmentation of funding had any consequence in terms of equity or in terms of ability of the providers to perhaps reach some underserved population, or come up with different ways of addressing those needs. Was that a constraint?
In Estonian context, it's the fragmentation is at when it comes to provider level, it's really everything is pulled together. So it's they don't have to report like it's how their spending or expenditures by these different payment methods. So that's not the case. That's rather like it's the revenue side. So their expenditure side, it's they have to be accountable, just that the second nurse is there or etc. But that's true. So it's the risk with this kind of voluntary approach is that for some regions, primary healthcare doctors, providers are very innovative and they're very much willing to take more role. And then there are certain areas where maybe optimism is not so huge, and that definitely is a risk to create inequities between different regions and that as well, like a different population groups. So that's definitely that one concern.
Are there any more questions specifically on provider payments, Tara?
Can I ask another question? Sorry, and I should know this, Triin, but your capitation is not risk adjusted. Is that correct? It's just it's a flat rate, or is the base capitation, is it risk adjusted?
It is age adjusted. So there are 5 age groups.
Okay. So you've got both risk adjustment and blending, just back to
Absolutely. Yeah.
the question that came from James at the beginning. So I hope that is clear, James, about the distinction between the two things.
Yeah, that's clear. Thank you.
Did you want to add anything, James?
Yeah, perhaps just to understand briefly about who finances capitations. Are they like insurance companies, or is it government managed kind of initiative? And I can imagine that this differs across countries.
Shall I have a first go at that? Yeah, I think one of the things we say in our report is that when the funding flows and channels are fragmented, so when you've got funding coming from out-of-pocket payments, let's say central government, local government, insurance funds, it's very hard to coordinate and have a coherent provider payment system that is trying to do things that, that is purposeful. And if you are going to have a sort of coherent system, that it does sort of require that there is a main funding mechanism that is paying providers, or that at least there's very good coordination between the different funding flows. Capitation systems, Kari, you can correct me if I'm wrong, but seem to me more used when it's government funding from general taxes. That seems to be the sort of more common model of a capitation. But I think there are examples of insurance also using insurance models using capitation as well.
I think that's right, Tim. In the US, HMOs, for example, were set up to pay providers on a capitation basis. That was private insurers that were using a capitation payment method as well. And in Estonia, Triin, the single payer is a social insurance fund, isn't it? Is it paid through a contributory mechanism, or is it tax funded?
It's a mix. So it has contributions and increasingly also budget transfers.
Yeah, can I come in?
Yeah, would that be a specific question, or I'm wondering whether we shall start moving on to the part of presentation on resource allocation and then go back to those broader questions perhaps towards the end?
That sounds like a good idea, Laura. That way we can make sure that we have enough time for Shankar, who I'm pleased has arrived.
Brilliant.
Okay.
Yeah, over to you, Cara, then. Thank you.
Thank you. Darius, would you mind showing my slides? Great. So the second part of the session is focused on the issues of resource allocation. Next slide, please, Darius. And so yeah, we kind of started from the point of observing that that governments aren't spending enough on PHC in low and middle income countries, and that the main mechanism for doing that is through budgets, through government budgets. If we're talking about public financing. And then so we talked about how, governments collect tax revenue, they allocate some to the health budget, and then some of the health budget is allocated to PHC. And then we started to unpack, well, what does it mean to allocate a health budget to a specific set of activities? And so what we wanted to do was to identify and explore the effectiveness of different types of policy levers that are used to allocate resources for PHC. And a second kind of observation that we made was that along this kind of allocation process, there's lots of pressure throughout the system for resources to get sucked away from primary healthcare, into other things, or even back up to the hospital level. So we had this sense of kind of allocating and protecting resources for PHC to make sure that they reach frontline providers. And we ended up classifying these policy levers into three main sets. So one has to do with how budgets are formulated, the second, how budgets are executed, and a third, which is possibly a bit less intuitive, is how the service delivery arrangements themselves can influence the allocation of resources to PHC and their protections, when they can be protected for that purpose. So we also observed that many countries use multiple tools at the same time. So it's not a matter of just using one, you have to use a whole armory of tools to allocate more resources to PHC and to protect them. And then an important starting point for this is knowing what you mean by PHC. And this goes back to one of the comments in the chat about the importance of context and having a country-specific operational definition of what the PHC platform looks like in a particular setting. And then a kind of a final observation on this was that this function of budgeting and planning for PHC, it needs to be clear who's responsible, and that because I think we were not interested in going down the lines of recommending a new PHC program that would have its own budgets, but rather that the responsibility for allocating money to PHC platforms should be clear, so that that office or office holders can be responsible for that, and also to increase the political support for primary healthcare. Next slide, please. So this is the way we classified these tools for allocating resources. I'll just say, I say this every time I give this part of the talk. I personally was really naive about what resource allocation involved. I sort of thought that our job was to say allocate more. I hadn't really thought before the commission work about what the mechanisms for doing that would be and how those differ in different types of settings. So this was a classification that we found as a useful way of highlighting the multiple different ways that that it's possible to allocate resources for PHC. So the first is the budget, and the budget is kind of at the core of these public systems. So within the general budgeting process, there are things like program budgets or budget rules and statutory appropriations, and that's what the subject of Shankar's contributions will be, or conditional grants that say if you allocate a certain amount then to PHC, then that will be matched, for example, through other sources. A second set of tools are about how budgets are actually executed. So here we've talked a little bit about capitation. Another formulation of capitation is as a resource allocation formula that uses an equal per capita allocation to some kind of budget holding unit that might not be a provider. Then there's a whole set of tools around purchasing, so specifying a benefit package, contracting providers, and exactly how providers are paid, so the provider payment mechanism. And we argue in the report that actually capitation is quite a good way of allocating and protecting those resources for PHC, because they get to PHC providers and then they are, in a sense, ring fence for PHC providers. There's not much risk that that money will drift back up the system or be recalled in some way. And then finally, in terms of service delivery, at the very beginning of the commission discussions, we started to talk about how the way the delivery system is structured can have an important influence on the resources that reach primary healthcare providers. And in particular, well, two things, I suppose. One is that you can use financing arrangements to drive changes in PHC delivery, and that's a point that Triin was making earlier. But also conversely, by changing your service configuration, that can be a useful way of pulling resources to primary healthcare. So if you think about places that created new cadres of primary healthcare workers, like the family practices in Estonia, or like health extension workers in Ethiopia, that kind of creates a thing that you have to fund. And that is one way of getting funds to the PHC level. Next slide, please. So I won't talk about any of these examples in details, but just to say that our report has lots of examples of each of these instruments. So in South Africa, for example, they have introduced program budgets that operate kind of in parallel and alongside the normal input-based budget that ministries of finance have tended to use. In Nigeria, the primary health, the basic health services something fund, I can't remember what the P is, but anyway, there's a fund that is directed to the PHC level that's based on a compulsory 1% share of general government revenue, and that is allocated to this primary healthcare provision fund. That's the P. In Brazil, they use a resource allocation formula to send money straight to municipalities that are responsible for PHC. In Tanzania, they've introduced direct facility funding, which is a way of sort of creating facility bank accounts that then receive and are accountable for funding, for cash funding for PHC. Thailand, as everybody knows, has really creatively used purchasing arrangements as a way of ensuring strong PHC levels, at least in rural areas. I think they've struggled a bit more in urban areas to get strong PHC. And I already mentioned the service configuration issues in Ethiopia and Estonia. Next slide, please. So just a last point, if you recall Tim's figure of this trajectory of provider payment, underlying that was a set of health system capacities that are needed in order to enable that transition from a fairly simple to a more complex provider payment system. And the same is very much true of resource allocation. So you can sort of see along the bottom panels here, the sorts of health system and public financial management capacities that are required to enable and support effective budget execution and budget formulation in favor of PHC. So I'm going to introduce Shankar, who's just joined us. So Shankar was the co-author of a case study for the Commission about the way that the National Health Mission uses some of these policy levers to encourage the states to spend on PHC. So over to you, Shankar. You're very welcome.
Thank you very much. I'll try and share my screen as well. I hope my slides are in full view.
Yep, perfect.
Thank you so much. So thank you very much for having me here. And this was a work that we did jointly with for the Lancet Commission. Basically, I'll try and run through some of the background methods and findings. So the whole premise before we began this entire exercise was that we tried mapping the entire funding flows for primary healthcare in India. And one of the things that we recognized, although this is a much more simplistic view of the entire funding flows, is that given the federal structure that we have, where there is a central allocation of resources that comes to the state, and then the state also, through its treasury, it allocates certain amount of money to the health department. So eventually the overall level of spending that the health department does is a mix of the money that it receives either from the state treasury or from the central route. And this, while the overall share of the central funding may not be very great, it's still an opportunity for the central government to nudge the states in order to either influence the extent of their spending or extend the patterns of spending for primary health care. So that was the basic background and the premise based on which we investigated this particular question, that what's the impact of the kind of central nudges through different policy levers that the central government has on both the extent and the pattern of funding for primary health care. And we also tried examining within this context of central state fiscal federalism, that what is the kind of role that the central government plays in overall shaping the agenda for health. And in particular, it was primary health care. And then eventually, what's the kind of impact that it has on equity and efficiency. So in order to do that, we selected a few states. We selected 4 states in particular, and these states were geographically different from each other. But the more important criteria that we used in order to select these states was the extent to which the central government contributed to the funding of the healthcare at the state level. And here we had 3 different categories of states. A state which has much lower share of the central funding in the overall state spending. A state where the central funding goes to almost a little over a third of the total state spending. And then we have 2 states which are relatively in the middle spectrum of the entire dispersion. So we selected these 4 states, and we presumed that if there is a greater share of allocation by the central government, then perhaps it has a greater negotiating power to influence the level of spending. Then in each of these 4 states, we tried examining, looking at the program implementation plans and the financial management reports, which give us a descriptive picture of what's the level of allocations and what are the level of spending that the states have had over the years. So we traced about 10-year journey that had there been any changes during these years, and we tried putting time points where certain major changes in the fiscal federal relations took place between the center and the state. The third, we tried examining, we had in-depth interviews with senior level policymakers, both at the central and the state level. And we tried understanding from them that what actually transpired during the process of those negotiations for the allocation of primary healthcare resources or funding, and how were these plans prepared, and was there any visible impact of this entire ecosystem that operated where the central government tried to shape the agenda. And then we also reviewed a lot of different policy documents that tried to articulate the relationship between the center and the state in terms of how much share does each of the different player contribute to, and what are the roles and responsibilities of each one of them. And then based on that, we tried doing the analysis. So in brief, there were 3 key instruments or policy levers that were being used by the central government in order to influence the funding for primary healthcare. The first, as Kara also mentioned in her opening remarks, that there were certain degree of conditionalities that the central share, which was to be allocated to the state, was linked to the state adhering to certain normative requirements. And incorporating certain programs or including certain interventions in the benefit package, etc. And the state share also was had to be equally compensated with the central grant that was released. So that those were one set of instrument. The second set of instrument were that the broader tax revenue that was being generated, the way it got devolved between the center and the state. In between, the Finance Commission made changes into the rules which allocated a greater share of the divisible pool to be shared with the state, and which meant that the allocation within the and this, because this greater amount of overall revenue now was being allocated to the state, so the allocations specifically for health and education were reduced accordingly. Sorry. And third, there was creation of a performance-based incentive. That means the central allocations to the state were contingent upon states meeting certain performance benchmarks. But these were not effectively assessed as part of our assessment, because these took place at a point of time beyond which we weren't able to assess the data and look at the impact, etc. So that's the third part. While it does exist as of now, our data is not able to comprehensively make any comment on that. So if you look at these two graphs, we have tried stratifying the states into the ones that are the larger states, which have a share of 60-40 sharing pattern between the center and the state, with the 60% coming from the central government and 40 from the state. But then we also have 11 states that were there, which had a funding arrangement where 90% of the share came from the central government and 10% from the state government. And in each of these two category of states, we tried looking at the temporal trends in terms of allocation of resources, both from the central government, which is reflected as the CSS, which is shown in the blue line, and the one in the orange line, which is the state allocations. So what we see in the states is that, and this is the time point when the Finance Commission recommendation came in. That means where the divisible pool allocation between the center and the state changed, and states were given a higher amount of divisible pool general revenue, which was to be used for allocating to health. So there was a typical shift that took place beyond this time point, where the state allocations began to rise, and the central allocation, they marginally decreased over the years. And for the other set of states where originally the center had a much higher allocation ratio to begin with, in those states, there was a steep decline in the central allocation, and the pattern actually completely transformed beyond this point of time. So this one particular reform that took place alongside the Finance Commission recommendation of changes in the allocation of the overall revenue had a significant impact on the share of the revenue allocations for health between the center and the state. The second set of policy levers that we identified that the central government used in order to determine the patterns of financing for primary healthcare was a set of joint planning exercise that was carried out each year for the next forthcoming year, where the state determined a plan of action by incorporating certain interventions, and those interventions were supposed to be funded. But the choice of these interventions or the programs were jointly discussed and agreed upon between the center and the state government. And that created an opportunity where during this planning process itself, the center exercised its power in order to set the agenda and influence the patterns of financing for primary healthcare. And so here again, we see that in terms of in all these years, as we move forward from 2008 till 2020, because of changes in the ratio of the allocation that the states had to put in the overall share, you can see this is typically for each of the 4 states. There was an increase in the spending by the states that took place as the sharing arrangement changed over the years. So starting from 15% share that was to be done by the state government, it gradually increased to 40% share after the Finance Commission recommendations. And as a result, you see that there is an increasing pattern of spending by the states. Where there's a central funding, it by and large remained either same or in certain cases, it actually declined. But the fact that this allocation is by and large increasing in all the states, it gave a bit of an idea that the extent to which a central government is contributing in a given state's overall share did not necessarily influence the extent of its ability to influence the funding decisions of the state. Although we do see that that the state of Bihar, for example, where you had the highest share of central government funding, it has the highest overall level of state allocations. But then the pattern remains the same in all the 4 states, which implies that perhaps just the fact that the central government has a certain amount of share in the overall state funding does not necessarily give it the kind of power to exercise the state decisions. But the other policy lever that we talked about, which was the power that it exercised at the point of agenda setting, was perhaps a bigger power, a bigger contributing factor, as well as the broader macroeconomic factors that were shaping decisions through the decisions of the Finance Commission, for that matter, which changed the overall allocation rules for the general revenue. Those were bigger contributing factors than just the center's overall share in a state's budget. The other important finding that we had was that despite the fact that that several state governments also concurred that there were several points or several items within the budget where their budgets were cut by the central government when they first submitted their plans. And you can see a sizable proportion of the overall budget line items witnessed a certain degree of control that was exercised by the state government in terms of changes in the budget. However, overall, it did not have very significant influence on the overall amount of budget that was approved. So if you look at the states by the time 2019-20, by and large, around 80 to 90% of the overall budget that was proposed by the state, that was approved by the central government. And there wasn't much difference across the different type of states as well. And we also see that there is a rising trend in terms of the approval rates. So what it means is that that the states perhaps started to toe the line of what the central government broader guidelines were, and they also started to understand how the plans were to be prepared, and as a result there were lesser instances where the budget cuts took place, etc. So overall, the central government also created several other opportunities whereby it started shaping the overall priorities and the agenda for funding primary healthcare. And there were various instances that we got to know through our stakeholder interviews, where common platforms of planning, and even there were opportunities which led because there were intersectoral coordination opportunities also that were created through this initiative of the central government, which meant that health got a better visibility even at the state level across the range of different other departments, which included other social sector programs as well. And there were a lot of other influences that the central government was able to introduce, such as the shift in from a more input to a more output-based measurement that took place. Finally, on the performance-based funding for primary healthcare, there were certain changes that were introduced. However, there were based on different views of the state government. By and large, the states opined much more negatively in terms of the introduction of these performance-based incentives, more related to the fact that they felt that it has a more lagged effect, or in certain cases, they felt that it might be unfair to states which have a poorer absorptive capacity, or the fact that the data sources that were being used for generating these performance incentives perhaps did not really reflect the actual situation. So those were some of the feedback that we received from the states and the different stakeholders. So finally, what are the implications for the based on the analysis that we did for other countries as well? What we found was that nudging the states did lead to increased spending for primary healthcare, and there were different levels of policy levers that were being used, and different power dynamics that operated between the center and the state. There were different instruments such as which included institutional arrangements, different conditionalities that were introduced for allocation of resources contingent upon performing certain set of tasks, etc. And also that there were contextual governance factors, as I mentioned, which were the kind of society structures that were created, which led to certain increased accountability frameworks that were put in within the health sector, which meant that primary healthcare gained a certain level of priority. We did also overall report that the performance-based funding, especially from the point of view of the stakeholders, there were certain negative consequences that were anticipated. So which meant that there needs to be a much more careful planning in order to perhaps identify the right set of indicators for introducing these incentives. So I'll stop here and happy to answer any questions there are.
That's great. Thank you very much, Shankar and Kara, for the two brilliant presentations. I think there's a question quite related to the last presentation by Bindia. Do you want to ask it yourself if you're online? Or I can read that out. Basically, that was asking Shankar about one of the last slides where there was a mention of conditionalities. And there was a request for explaining what did you mean exactly by conditionality in the context?
Yeah, I think the conditionalities is primarily linked to the fact that with each tranche of central government grant that was released to the state had to adhere to certain broad principles in terms of allocation. So there were certain allocation rules. So for example, in the overall amount of resources that you spend, you cannot spend more than a certain proportion on, let's say, capital creation, or B, there are a certain set of services or programs that you have to necessarily incorporate into your plan. So those were the type of conditionalities that were created.
Thank you. There's one more question from James. I can see a raised hand.
Yeah, thank you. Just a quick one. I wanted to know, you mentioned something around shift from creating infrastructure to improvement in service delivery. I'm interested in knowing whether that's already something that has taken place and what's the response from stakeholders, especially the political side, both at the national and state levels. How are they responding to that shift?
Yeah.
And what strategies are, over.
Sure. So I think that it was a very sort of well thought of shift that took place as part of the NHM funding arrangements. So what it meant was that originally the entire funding was a typical supply side funding arrangement, wherein the entire funding was allocated to creating an infrastructure or creating the supply of services, which meant placing doctors, and these were kind of line item budgeting, principally to generate the supply of resources. However, the shift that took place in the NHM funding was that it became typically an activity-based funding. So you list out that what are the number of services that you would like to deliver, and based on that, a certain amount of budget was linked to that. And there were quarterly grants that were released during the entire year, and each subsequent quarter's grant was contingent upon you meeting a given state meeting the necessary service delivery targets that it had stated. So an X number of institutional deliveries or a Y number of immunization sessions, etc. So there was a quantification of the services that to be delivered, which had a clear linkage with the amount of budget that was allocated to it. And that's how the shift from a pure supply side funding to a relatively more activity-based funding where it's linked to service delivery took place.
Yeah. Thank you very much. Maybe perhaps I would reach out on the side, but I would be interested in understanding the performance-based financing. Is it who is financing that? Is it government? Is it partners? Or how is that kind of contracting happening?
So it's just very briefly, I think the entire funding is by the government. It's completely tax funded scheme. So it's the tax revenue that is used to pay for the healthcare services. And the allocation, it's just the role, the funding flows is such that a certain amount of money comes from the central government and certain amount of money comes from the state government.
Any more questions? I had a question myself, because I think, Shankar, you had a mention to macroeconomic factors that change the rules for revenue allocation. I think you refer to state level revenue allocation, if I'm right. So I was wondering what were these, and then related to this point, whether there's any evidence of potential trade-off between allocation of resources for primary care within the health sector at the state level, and perhaps allocation to other sectors that I can think typically of education or water and sanitation, that are sectors that don't provide primary care, but that might be having relevant spending for health promotion or prevention. So I wonder whether there was a discussion about intersectorial allocation and whether that affected primary care specifically.
Sure. I think that's a very interesting question. We did not specifically go beyond the health sector allocations, but just to say that the whole context in which this policy lever operates is that it's the overall general revenue distribution between the center and the state that was, the rules of that sharing were changed beyond 2015. So earlier, prior to 2015, a greater amount of the general revenue pool went to the central government. But subsequent to 2015, because the states asked for a greater devolution of resources, there was a greater share that was allocated of this general revenue to the states. And the agreement was that if this general revenue, there's a greater allocation of the general revenue to the states, then the states are expected to spend more now on health, on social sectors like health, education, etc. Now, our analysis, so some people were skeptical that even if you allocate a greater amount of general revenue, that may not necessarily translate to a similar increase in the allocations to social sectors at the state level, because the priorities at the state level may change and they might allocate more to industry or to, let's say, agriculture or likewise. But our analysis so far does not seem to suggest that that there was a kind of a shift in that, because the state shares did go up, at least in primary healthcare. So the level of the level of priority that was placed on health did not necessarily go down. So, but definitely the point that you're raising for the other sectors and how the allocations of those sectors and did influence the overall primary healthcare spending, I think we may not have done that thorough work in terms of the analysis.
Yes, Cara, please.
Can I ask a question to Shankar? So that's my sort of third set of tools were about the configuration of service delivery. And another one of the big changes of the National Health Mission in the recent years has been these health and wellness centers. Could you comment on whether you think that change in the service delivery model has played a role as well in helping, in a sense, to have something to spend the money on in the NHM? Has it pulled resources to the PHC level as well through that vehicle of creating a new a new set of health facilities?
So I think so the duration of our analysis did not necessarily cover the health and wellness centers, but I think that the overall emphasis on the health and wellness center creation in itself, the fact that it places a greater requirement for infrastructure creation and the emphasis that it creates on creation of a new cadre of healthcare professional at that level, which is a community health officer, automatically implies that there is going to be an increase in the allocation for primary healthcare. And in fact, linked with that is the creation of another separate channel of funding that has also now been created, which is called the Ayushman Bharat Infrastructure Mission, which actually has been created it has a significant focus on tertiary care and the secondary care as well, but it does have a certain amount of contribution on the primary care side as well, although that has much more of a focus on tertiary care and secondary care.
Thank you. Any more questions specifically on this presentation or related to the whole webinar? If there are not more specific questions, I think we might actually go back to a question that Jacopo was asking just in the previous question break. That I don't know whether Jacopo you want to ask it yourself, but I think that basically was about the importance of the context in shaping primary care financing reforms, and whether I think there were any specific thoughts maybe from any of the speaker about what those contextual factors could be, or which one would be the most important in your opinion after all of these exercises.
So I could maybe start, Laura. So I think it's a great question, Jacopo, and I think I can think of two elements of context that might be important. So one is about the political and social and economic context. So and that kind of affects not so much what the trajectory looks like, but potentially the timing of the trajectory. So at what point is it possible to get enough stakeholder and political support for any substantial changes to the kind of primary healthcare financing arrangements? So that might be an increase in spending, or it might be the creation of a new cadre of which would, I think, we're not suggesting that there needs to be a new cadre, but in some places the creation of that cadre has been an important political strategy as well. And a third one might be your ability to change provider payment arrangements, because that is another very political question, because it involves kind of redistribution of resources. So I think that context is really important. I think the other issue is about it is about the speed of change. So and I think you'll have seen in both my figure and also in Tim's that there's a strong sense that in order to advance on any of these arrangements, whether it's allocating and channeling more resources or changing provider payment, that it needs substantial capacities. And actually going back to, I think Ian had a point in the chat as well about the a system's ability to generate data and to use data in decision making. And I think that might also be an important contextual factor that influences the pace of change. Yes, I would start there. I don't know if anybody else in my team wants to suggest anything additional, or indeed Triin or Shankar, if you want to suggest anything more about context as well.
I think one of the factors that we definitely identified in our context was the governance. And within governance, I think there are two contextual factors. One are the kind of governance structures that you create. And in the governance structures, there were two important things. One was the kind of opportunities that you created for the kind of joint plannings within a federal structure with the central and the state government coming in. And that opened up a lot of room for the kind of role that different actors played according to the extent of power that they exercise. The second was the structures that you created at the state level as well as at different facility levels, which increased the level of accountability that the health sector had for performance, not just at the overall governance level at the state level, but also to the community. So there was a significant emphasis on community empowerment and accountability at that level, at the facility level. So that's one thing. The second is the governance of the funding flow itself. So, one of the reasons that was very clearly articulated by several respondents in our in-depth analysis was that while there is a lot of talk about the absorptive capacity at the state and at the district level, a lot to deal with that low absorptive capacity is the fact that there are delayed levels of payment. And when there are delayed levels of payment, there is lower absorption. And that lower absorption means that the next year you automatically reduce the grant. So it becomes a kind of a downward spiral in the overall funding flow. So, but the root cause of that is the governance of the funding flow itself. So I think those two contextual factors, I think would be also very important to consider.
Thanks, Shankar. And Triin, did you want to add something from your experience?
Yes, it's just to maybe complement what Kara already mentioned. It's this political aspect of that, and I think it's if we look at student experiences, then this really broad-based political consensus when it comes to really primary healthcare reform design and towards what direction it should move and what should be primary healthcare's role compared to other providers, especially hospitals, which are definitely much more powerful. And that broad-based consensus has really assured that even if there is a change in political leadership, it's as well as central and local level politics. So it's a changes there, power games there. So this broad-based consensus has assured that it's primary healthcare development can make a progress independently of all this political struggle there. Over.
Sorry, Tim, did you want to add anything?
Yes, just a very quick point on provider payment. I think when it comes to contextual factors, we did recognize that there is probably a group of countries where it is not a good idea to start maybe tinkering around with a provider payment system, and that's for a later stage. And maybe the priority is using the existing mechanism to get more money and resources down to the provider level before thinking about changing provider payment. You do need some sort of basic systems in place, particularly financial management, before thinking about doing that.
That's right. As you think about sort of in places where budget execution problems are really serious, so money just is, budgets are released late and budgets are not, the money is not flowing to the decentralized levels, then I think to start messing with that and to sharpen incentives seems like dealing with the wrong problem, to deal with the right problem at the right time.
That was great and very comprehensive, I think, although I guess this work must have been quite challenging, and I'm sure that there will be many more findings to share and to reflect on, but hopefully there'll be other opportunities. If there are no more questions or any final thoughts from the speakers, no, then I think it's just thanking all the 5 of you for joining us today and giving us the chance to reflect on primary care financing. And thank you to those who also joined the seminar. Well, many of them have now left.
Sarah, thanks everyone.
Nice to see you all. Bye.
Thank you.
Thank you.
Bye.
Bye, everyone.
Thank you, everyone. Bye-bye.
Chum.